Morning, students. Today we are starting a new chapter on glaucoma. Before we step into the glaucoma proper, we need to know the basics of anatomy of anterior chamber angle, which is the main seat for glaucoma. Glaucoma is a disease consisting of triad of raised intraocular pressure, optic disc changes, and visual field defects. The raised intraocular pressure is the major risk factor which may or may not be present. But in recent past, there are other reasons where you can get glaucoma, like normotensive glaucoma, without raised intraocular pressure. But raised intraocular pressure is the major risk factor in development of glaucoma. So we need to know the major reasons why there is raised intraocular pressure. To know the raised intraocular pressure, we need to have a basic knowledge about the various chambers of the eyeball. In eyeball, we have got anterior chamber and posterior chamber. Anterior chamber is the one which is present behind the cornea and in front of the iris, whereas posterior chamber is the one which is present in front of the lens and behind the iris. So the aqueous fluid goes from the posterior chamber to the anterior chamber, and it has to leave the eye through the angle of the anterior chamber. If there is any defect in this process, there will be raised intraocular pressure which is on the eye and which causes the optic nerve damage. So for this reason, we need to know the various structures in the anterior chamber angle and what are the structures and how aqueous flows into the from anterior chamber into the out of the eye. Anterior chamber. So this is the main structure which is present behind the cornea. So it is a part of eye located between the cornea and the iris and contains the trabecular meshwork at the angle. The size of the angle is an important determinant for the rate of the aqueous flow. If angle is very big, the aqueous flow is normal, whereas angle is very small, the aqueous flow will be defective. To know some of the metrics of the anterior chamber is usually 2.5 to 3 millimeters in depth, holds 0.25 millimeters of aqueous at any given time. The wide angle of the anterior chamber denotes eye in which the angle between the iris and the surface of the trabecular meshwork is 20 to 45 degrees, whereas angle less than 20 degrees is termed as narrow angles. This is as per the Schaeffer's grading. This will come when we go to the various types of the glaucomas. Now, seeing at this picture, we can see the what is the types of what is the anterior chamber and what is the angle of the anterior chamber. So, as we have discussed before, this is the anterior chamber and this is the posterior chamber. Anterior chamber, anteriorly you have got cornea and posteriorly you have got iris, and the area where the anterior and the cornea and the iris are meeting is the angle of the anterior chamber. Here there is the trabecular meshwork. This trabecular meshwork is a sieve-like structure which from where the aqueous flows out of the eye into the Schlemm's canal. This is the Schlemm's canal which we can see, and from where it is drained into the venous structures. If there is any obstruction at this level, then there is a buildup of the pressure, and this pressure raised is known as intraocular pressure raise. And this is posterior chamber. Here the aqueous is secreted in the posterior chamber, ciliary process. From the posterior chamber, the aqueous flows through the pupillary area into the anterior chamber, and from the anterior chamber it has to go out of the eye through the trabecular meshwork. So angle of the anterior chamber is very important where trabecular meshwork and Schlemm's canal are situated. Now we should know the development of the anterior chamber angle because there are certain developmental anomalies which are responsible for the congenital glaucomas. So development usually takes from the neuroectoderm and neural crest cells. It starts at the level of 6 to 7 feet of fetal life, and first trabecular endothelium is the first to appear. Then at third month, appearance of anterior chamber is seen, where anterior chamber slowly invaginates and forms a chamber-like structure. In fourth month, canal of Schlemm appears. This canal of Schlemm is the one which is present after the trabecular meshwork, and it connects to the various aqueous veins and the venous system of the eyeball, from where the aqueous is flowed out from the eyeball. At the 8th month, anterior chamber angle formation is completed. Now looking at the structures, we see the boundaries of the anterior chamber angle as we have seen in the picture earlier. Anteriorly, there is inner surface of the cornea, and at periphery, there is trabecular meshwork at the angle. Then posteriorly, there is lens, anterior surface of the iris, and anterior face of the ciliary body. Looking at this picture, this is the ultrastructure of the anterior chamber and angle of the eye. Here it is cornea, Descemet's membrane, and Descemet's membrane which continues as a soluble scan, which we have seen in the previous classes of the cornea. And here this is the anterior chamber and this is the posterior chamber. The aqueous is secreted the ciliary process. It comes to the posterior chamber. From posterior chamber, it goes into the anterior chamber through the pupil. And from the pupil, it enters the anterior chamber. And after anterior chamber, it goes into the trabecular meshwork. From trabecular meshwork, is entered into the Schlemm's canal, from where it is drained into the aqueous vein. The Schlemm's canal and aqueous veins will be describing in later part of this class. Okay. So this is the part of anterior chamber angle. This we can see the anterior chamber angle, which consists of trabecular meshwork, Schlemm's canal, ciliary body, iris. So now coming to the structures of the anterior chamber angle, which are seen through the gonioscopy. From anterior to posterior, we have got Schwalbe's line, which we had discussed in the previous classes of the cornea, which is continuation of the Descemet's membrane into the angle. This is in white line. Then there is a trabecular meshwork, then scleral spur, and ciliary body band is the posterior most part which is seen. Now you can see this is the Schwalbe's line, which is continuation of the Descemet's membrane. Then you have got trabecular meshwork, then scleral spur, and ciliary body band. If all four structures are seen, then this is known as wide open angle. If there is wide open angle, the aqueous can freely flow out of the eyeball through the Schlemm's canal into the aqueous veins and the venous system of the eye. So here, this is the Schwalbe's line. Then there is a trabecular meshwork, scleral spur, and the dark part is the ciliary body band. Now, as we have seen earlier, this marks the anterior border of the angle of the and represents the termination of the Descemet's membrane. This is Schwalbe's line. This is seen as a glistening white line in the gonioscopy. Here you can see the glistening white line, which is seen in the gonioscopy, where three-dimensional parallelepiped is converted into a two-dimensional structure. This is a three-dimensional parallelepiped which is seen in the gonioscopy, which is converted into the two-dimensional structure. This termination is the termination of Descemet's membrane, and there is a beginning of the Schwalbe's line. This picture again, this cross section which you can see, this is the Descemet's membrane. This Descemet's membrane is terminating here. From here, the Schwalbe's line starts. This Schwalbe's line forms the anterior border of the angle. This is the first structure to be seen anteriorly on gonioscopy in the anterior chamber angle on gonioscopy. Coming to the trabecular meshwork, it is a sieve-like structure which is present at the anterior chamber angle. It is responsible for filtration of the aqueous out of the eye through Schlemm's canal. Now we have got two divisions in case of trabecular meshwork. Trabecular meshwork, there is anatomical division which is corneoscleral, which is nearer to the cornea, uveal, which is present at the uveal part, and juxtacanalular, which is near to the Schlemm's canal. This is the Schlemm's canal. The trabecular meshwork, which is present nearer to the Schlemm's canal, the juxtacanalular, which is nearer to the ciliary body and the iris, it is the uveal, and which is nearer to the cornea, it is the corneoscleral. And the most filtering part is the juxtacanalular part, which filters the aqueous into the Schlemm's canal. This is the structure again. Going back, we can see this is the sieve-like structure which is seen, from which the aqueous flows out into the Schlemm's canal. Now there is again functional division of the trabecular meshwork, which usually is seen on the gonioscopy. This is non-pigmented and pigmented. Pigmented part is the filtering part, and non-pigment is the non-filtering part. At the young age, both non-pigmented and pigmented are similar. You cannot differentiate much at birth between pigmented and non-pigmented. But as the age advances, since the aqueous keeps on flowing to the trabecular meshwork, the iris pigments which get deposited into the trabecular meshwork make it pigmented part. That's why we tell it is a filtering part, because it is continuously filtering the aqueous. So the iris pigments which are slowly getting dissipated and degenerated, they get deposited over the trabecular meshwork and make it a pigmented one. Here you can see this is a non-pigmented trabecular meshwork which has become yellow now. This is non-pigmented. This is non-filtering part. This is not going to filter. This is usually at the corneoscleral junction or uveal junction. And next is the filtering part. This is, you can see the filtering part which has turned into blue now. This is the filtering part which is pigmented. This pigment, it has accumulated over the years, since there is continuous filtration of the aqueous through the trabecular meshwork. Next structure which is seen from anterior to posterior in the angle is scleral spur. This has got very much importance in case of angle occlusion and open angle glaucoma. This is a ridge of scleral tissue that lies anterior to the ciliary body band, and marks the posterior border of the trabecular meshwork. At the end of the trabecular meshwork, the ciliary body, a scleral spur starts. Here you can see it is a wedge-shaped circular ridge. This is a wedge-shaped circular ridge which you can see here. It is a prominent white line on gonoscopy. It is anterior to the ciliary body band. It is anterior to the ciliary body band, and this contraction of the ciliary muscle pulls the spur posteriorly. This will explain next later in this class how it pulls and how it makes the aqueous to flow out, and how various drugs act on this. The scleral spur prevents ciliary muscle from causing Schlem's canal to collapse. Okay. So here you can see, I'll explain you how the scleral spur is acting. This red line which you are seeing is a ciliary muscle. This is the longitudinal ciliary muscles, and this is the scleral spur which you are seeing. This is the scleral spur which is present, and this ciliary muscle which gets attached to the scleral spur. So there is an attachment of the longitudinal ciliary muscles to the scleral spur, and this is the here you can see the trabecular meshwork. This is the trabecular meshwork, and this is the Schlem's canal. So what happens now is once the ciliary muscle contracts, it will pull the once the ciliary muscle contracts, it will pull the scleral spur back posteriorly. It is going to pull the once the ciliary muscle is contracting here, this is pulling the scleral spur posteriorly towards the lens and ciliary body. Once this pulls, this trabecular meshwork which is present, which opens. This trabecular meshwork opens and the angle widens and the aqueous slowly flows out of the angle of the anterior chamber. Again, we'll go through this. See, there is a ciliary muscle here, longitudinal ciliary muscle, which is attached to the scleral spur. Once there is contraction of the longitudinal ciliary spur, the attachment of the trabecular meshwork to the scleral spur will open the trabecular meshwork. Once the trabecular meshwork is opened, the aqueous flows out of the angle of the anterior chamber into the Schlem's canal and into the aqueous veins. This is how the scleral spur, there is importance of the scleral spur. So in various drugs like pilocarpine which act on the ciliary muscle, it will contract the ciliary muscle and making the angle to open. Last structure which is seen on the gonoscopy is ciliary body band. This ciliary body band is seen as light gray to dark brown band located just anterior to the iris and posterior to the scleral spur. This is the end. It lies just behind the scleral spur, and portion of ciliary body band which is visible in the angle as a result of insertion of iris into the ciliary body. This is insertion of the iris into the ciliary body. So it is usually seen, this ciliary body band is usually seen in the open angles, wide open angles. If ciliary body band is seen, we tell that this angle is wide open, so the aqueous flow will be easy. And there are certain pathological conditions where you can see the wide or open ciliary body band, that is in case of traumatic glaucoma. In trauma, where there is disinsertion of the ciliary body band, you see the wide ciliary body band. Then we come to the physiological aspects, how the aqueous humor flows. Aqueous is usually secreted through the ciliary process of the ciliary body. It flows from the posterior chamber into the pupil, then into the anterior chamber, then it goes to the angle of the anterior chamber and passes through the filtering part of the trabecular meshwork, enters the Schlem's canal, and from where it goes into the aqueous veins and the scleral veins. This picture will denote you how it is going. See here, you can see the ciliary process are secreting the aqueous. Aqueous has come to the posterior chamber. From posterior chamber, it is going into the anterior chamber through the pupillary area. This is the pupil. And from anterior chamber, it is going into the trabecular meshwork. From trabecular meshwork, it is passing into the Schlem's canal. From Schlem's canal, it is going out. So this is the process of aqueous humor flow, and 75% of your aqueous is filtered through this conventional. This is known as conventional pathway of aqueous outflow. There is non-conventional pathway which filters about 20 to 25%. This is through UV scleral outflow and cornea. UV scleral outflow is through the absorption of the iris layers. So through the absorption of the iris layers, there is 20 to 25% of absorption of aqueous, and rest of the aqueous has to leave the eye through the conventional outflow, which is through the angle of the anterior chamber, passing through the trabecular meshwork, Schlem's canal, and into the aqueous veins. So this is the trabecular outflow. This is known as conventional outflow, is also known as trabecular outflow, and non-conventional outflow is known as UV scleral outflow. This is UV scleral outflow. This is trabecular outflow. In UV scleral outflow, it is getting absorbed to the surface of the uvea and sclera. In trabecular outflow, it is going through the trabecular meshwork and Schlemm's canal into the aqueous veins. So 70 to 80% of your aqueous drains to the trabecular outflow. Now coming to the Schlemm's canal, all the time we have been telling that after trabecular meshwork, it goes into the Schlemm's canal. What is Schlemm's canal? It is an elastic structure which is collapsible structure which is present through 360 degrees of the eye. So here is the Schlemm's canal. If you take a cross section, if you take a sagittal section, this is the 360 degrees Schlemm's canal is present, and this is connected to the scleral spur. Once the scleral spur is once the ciliary muscle contracts, the scleral spur opens. This scleral spur pulls and Schlemm's canal opens. Once the Schlemm's canal opens, the aqueous drain to the trabecular meshwork can go into the Schlemm's canal, and this Schlemm's canal again drains into the aqueous veins. These are the aqueous veins which are surrounding the Schlemm's canal. This white one is the Schlemm's canal. Here you will see trabecular meshwork. The aqueous comes, passes through the trabecular meshwork, enters the Schlemm's canal. From Schlemm's canal, it enters into the aqueous veins. These are the aqueous veins surrounding the whole 360 degrees. And this aqueous veins drain into the episcleral veins and the venous system of the eye. Now, after listening to all these things of angle, structure, what is the importance of each structure, how aqueous flows from its originating posterior chamber to the anterior chamber and into the aqueous veins. Now we have to differentiate between the open angle and closed angle. What is open angle? What is closed angle? Here we are going to differentiate in the same picture how it is open angle and closed angles are differentiated. Here, this picture you can see it is open angle picture. This here ciliary body. The aqueous has come here. It is passing through the posterior chamber. This is in front of the lens. From the pupillary area, it is going into the anterior chamber. From the anterior chamber, it is going into the trabecular meshwork. So there is a wide space between the iris and the cornea, and angle is open, and trabecular meshwork is free to receive the aqueous and channelize into the Schlemm's canal. This is open angle. Why you get open angle glaucoma? This glaucoma can be, there is any defect at this level, there can be open angle glaucoma. Angle is open, but there should be some foreign body, foreign material which is obstructing the flow of the aqueous, or there should be something in the trabecular meshwork which has thickened and blocked, which can cause open angle glaucoma. This we will discuss in detail when we are discussing about the types of glaucoma. Now coming to the closed angle glaucoma, here you can see the iris lens diaphragm has moved front. You can see the lens is at back now. Here the iris lens diaphragm has moved front, which is causing block in the pupillary area. Here there is a space between the pupil and the lens. The aqueous is able to pass from the posterior chamber to the anterior chamber. Whereas here there is a block. This is known as iridolenticular contact. This iridolenticular contact will cause a pressure in the posterior chamber. This pressure in the posterior chamber will further raise the iris and it will get opposed nearer to the cornea. Once this gets opposed to the nearer to the cornea, the angle which was open here is closed. Angle which was open here is closed. That's why in case of closed angle glaucoma, you see shallow anterior chamber. Here, anterior chamber is not shallow. Here you can see the shallow anterior chamber where the iris is bulging forwards and it is causing the angle to close. So there is no way the aqueous can escape through the trabecular meshwork. So this is a closed angle. The difference between the open angle and closed angle is iris is flat here, iris is bulged here in closed angle, iris is flat in the open angle. Iris lens diaphragm is moved front in the closed angle, whereas iris lens diaphragm is back in the open angle. And there is a block, pupillary block. This is known as pupillary block, where there is an iridolenticular contact, which will not allow the aqueous to pass through from posterior chamber into the anterior chamber. That's why we create a special passage by laser iridotomy in angle closure glaucomas, which will cause an alternative route for aqueous to go from posterior chamber to the anterior chamber. This will be discussed in detail when we are dealing with the angle closure glaucoma. I hope you have understood the various anatomical structures, how the aqueous moves from the posterior chamber to the anterior chamber, and what is the reason behind calling an open angle or closed angle, and what are the structures in the angle which are causing the aqueous to flow out, trabecular outflow and UV scleral outflow. Thank you. Any questions, you can update it on the Schoology app. We'll be able to answer it. Thank you very much.